When patients present with relapsed refractory lymphoma, there are several factors to consider. One of them, of course, is how soon after initial therapy relapse has occurred. And patients who relapse within 24 months after initial therapy have poorer prognosis compared to patients who relapse later in their disease. So for those patients who relapse late, say 7, 8, 10 years after initial therapy, repeating chemoimmunotherapy is a very viable choice. And if they received CHOP rituximab combination in the past, one could use bendamustine rituximab or bendamustine obinutuzumab. One could potentially even repeat CHOP if those patients don't have cardiac comorbidities, for example. In patients who progress within 24 months of initial therapy, the choices become somewhat harder and more limited. Typically for those patients, you can still use chemoimmunotherapy again. However, one would expect that they may not respond as well, and it may be beneficial to use some of the novel agents. Recently, a combination of lenalidomide rituximab has been approved in therapy of relapsed follicular lymphoma based on the results of the AUGMENT clinical trial, where lenalidomide rituximab combination demonstrated benefit and progression-free survival over rituximab alone. So for patients with high-risk disease who progress early, that potentially could be a good option, as this treatment does not target the same pathway as chemotherapy. This remains an area of unmet medical need, and investigations are ongoing, including cooperative group trials, which try to really zone in on this patient population and determine what is the best therapy for those patients.
Whatever you use in the beginning to treat your patient will definitely influence what happens afterwards. And that's because some treatments have a lifetime dose limit. For example, if you treat your patient with R-CHOP, then you have 6 cycles of anthracycline for maybe the dose limit for that particular patient. So you wouldn't repeat R-CHOP if they relapse at some point in the future. So that, for example, is a perfect example of how what you begin with influences what you do next. However, bendamustine is a little bit different. There's no dose limit to bendamustine. However, few, I think, would repeat bendamustine after 6 cycles because you can develop a lot of cytopenias. So those are the 2 most commonly used induction regimens for frontline treatment, and they often get repeated second line, but most often they don't. Most often you would choose to use something different. And right now we have several FDA-approved treatments for relapsed follicular lymphoma. As I mentioned, lenalidomide and rituximab was just approved by the FDA on May 28th for relapsed follicular lymphoma and marginal zone lymphoma. And then we also have 3 different PI3 kinase inhibitors with varying side effects that can also be used in the relapse setting. So you don't have to necessarily repeat what was used in the beginning. Some patients might even get single-agent rituximab at the time of relapse because it's a relatively asymptomatic relapse and much time has elapsed from the beginning of their treatment to when their disease recurred. So you don't necessarily have to worry about repeating the treatment that you used in the beginning. In general, though, most patients with follicular lymphoma treated with either R-CHOP or bendamustine have a long duration of response. The vast majority of them will have a very durable disease control. So there's a recent study that was published some time ago now, maybe a year or so ago, that was an updated analysis of SWOG 1608. It was an updated analysis of SWOG 0016, which was a very large U.S. intergroup study looking at CHOP versus R-CHOP, CHOP with radioimmunotherapy versus R-CHOP. And that study showed that at 10 years, 80% of patients with follicular lymphoma were still alive. So that tells us that it matters what you use in the beginning, but the vast majority of patients will do very well. So I think what we need to focus on is finding the patients who are less likely to do well so that you can treat those patients differently.